Hello, everyone. Welcome to this webinar organized by Olea Medical. The topic of the day is imaging of the breast after oncoplastic surgery. My name is Frank Girard, and I will be your host tonight. Before I go further, I want to review the functionality of Zoom. Your active participation is important during the session. Right now, I have everyone on mute to avoid background noises. Throughout the presentation, you can ask your questions in the question and answers section. They will be answered later, together with the retranscript of the video by our host. Now, I'm very pleased to welcome you all and introduce you to Professor Dr. Boris Brkljačić. I hope you will forgive my bad pronunciation of his name. Please do not forget, I am French. Unfortunately, Professor Brkljačić is not with us tonight for personal reasons, but he has recorded his entire presentation and he will be able to display it now. And we will be able to listen to him tonight. His presentation will last for approximately 30 minutes. Dr. Brkljačić is Professor of Radiology at the Medical School of the University of Zagreb, Croatia. After a fellowship in Philadelphia, USA, Dr. Brkljačić came back to Zagreb and occupied various positions until he was named chairman of the Department of Diagnostic and Interventional Radiology. In parallel to his medical duties, Professor Brkljačić has conducted research activities and is immediate past president of the European Society of Radiology in Vienna, is the chair of the program committee of the IS3R, Secretary General of the International Society of Radiology in Reston in the USA, and adjunct professor in radiology, Faculty of Medicine, Hebrew University of Jerusalem. Well, Dr. Brkljačić, thanks very much for your participation, even though through the video, and we are looking forward to listening to your talk. Enjoy the webinar. Your questions will be answered afterwards and sent with the replay.
Good evening, ladies and gentlemen. Boris Brkljačić. I'm professor of radiology at University of Zagreb School of Medicine, and I'm going to speak about a topic of imaging of the breast after oncoplastic surgery. We know that there are more and more neoadjuvant chemotherapies now as a first line of therapy in breast cancer, but still oncoplastic surgery is very important, very common, and we need to follow some rules that I would like to talk about today. So, imaging in post-operative breast after surgery for cancer is used to differentiate residual or recurrent cancer versus scar or benign changes. And we know that mammography and ultrasound in this setting are often inconclusive. MRI is very important to detect breast cancer recurrences, and MRI can do it at a smaller size than can be clinically appreciated, and also as early as possible without evidence of metastasis, which is important for further treatment. Now, regarding oncologic surgical methods, most commonly used now is breast conserving surgery or quadrantectomy, mastectomy or mastectomy with reconstruction using either prosthetic implants or autologous myocutaneous tissue flaps like latissimus dorsi, transversus abdominis, deep inferior epigastric flap is used very often. And also reduction mammoplasty is used sometimes, and we need to also mention it. So immediately after surgery, we should evaluate whether there is a residual disease, if there are positive margins at histopathology, and MRI is excellent to diagnose residual cancer at surgical site. Regarding long-term imaging surveillance, the aim is to detect ipsilateral and contralateral, both breast cancer and axillary recurrence. Risk of recurrence is some 10 to 15% within 15 years, so it's not low. After mastectomy without reconstruction, usually in unreconstructed mastectomy site, recurrence is detected by shear physical exam, and unless sufficient amount of tissue is present to compress for adequate view, mammography is useless in this setting. It's performed only for the contralateral breast, so we have ultrasound and MRI on our disposal. This is an example of a lady who was 58 years old. She had mastectomy 10 years ago when she was 48 for invasive ductal cancer of the right breast, and left breast is normal. And this is B-mode ultrasound of the right side of thoracic wall, where we see this small hypoechoic lesion, only 5 millimeters in diameter, of vertical orientation, which is very stiff on shear wave elastography. So this is MRI of the same patient. We see here enhancing mass, and this was the recurrence of cancer. We see here washout type of the curve. So cancer recurrences on thoracic wall, these are stiff, irregular hypoechoic masses enhancing on MRI with washout curve. It's relatively easy and straightforward diagnosis. This is another example, 61 years old lady who had mastectomy for invasive lobular cancer 2 years ago. She has now focal small lesion adjacent to scar. Fine needle aspiration cytology was benign, and here we see that it is elastic soft lesion. It was benign. This is an example of contralateral recurrence after mastectomy in a 67 years old lady. She had mastectomy 10 years ago due to grade 3 invasive ductal cancer, and now she has recurrence in the left breast, where we see also color Doppler and shear wave sonoelastography with very stiff recurrent lesion. And then we have imaging after breast conserving surgery, so where the bulk of the breast is preserved. And we know that breast conserving surgery combined with sentinel lymph node mapping to decrease number of unnecessary dissections of axillary lymph nodes, which is then followed by radiotherapy and chemo or hormonotherapy, is now established modality of treatment for small breast cancers. Basically, we do breast conserving surgery when whole entire cancer can be resected with good cosmetic result. It of course depends on breast size, on location, on extent of breast cancer, on incision site, which is all important for planning. And basically, if we compare breast conserving surgery to mastectomy, they are more or less similar in control of the local disease and survival in patients who have smaller breast cancers less than 4 centimeters, regardless of positivity of lymph nodes. Now, after breast conserving surgery, in many cases, residual tumor remains in the breast. In large studies, long ago, it was published that 14% of women had involved margins and 17% so-called closed margins, where tumor was within 1 millimeter. 17% underwent re-excision, of whom 1/3 had residual disease identified. And then even with a 2 centimeter free margin, 11% of patients harbor additional tumor foci in the breast. So residual disease is suggested by positive margins or residual tumor calcifications on mammography, but of course MRI is the best because we see clumped, bulky, irregular or other enhancement at the site of surgery or extending from post-operative seroma. We have to remember that smooth enhancement of the wall of seroma is normal on MRI. Let's see some clinical examples. This is a young lady, 39 years old. She had breast conserving surgery in another hospital where preoperative MRI was performed, and also MRI 6 months after surgery. It was grade 2 invasive ductal cancer, hair positive. So luminal B hair positive. She was referred to our hospital for biopsy and reoperation after the post-operative MRI. This is preoperative MRI before surgery, where we see enhancing lesion, also on MIP. This is tumor. After surgery, we see large seroma, which is T2 hyperintense, but we see residual cancer. It was almost not removed at all. So this is surgical failure. This was now almost 9 years ago, but we see it less and less, I have to say. We are very lucky in my institution that we have excellent breast surgery unit, but this can be still seen especially in surgeons who don't have a big experience. This is the same patient with shear wave elastography. You see this lesion that on B mode is suspicious, but on shear wave you clearly see that it is very, very stiff lesion with more than 200 kilopascals, Young's modulus of elasticity, and of course it was residual cancer. This is another example, very young lady, 28 years. Actually, she had operative biopsy performed of 2 masses in right breast without proper preoperative imaging. It was envisaged that these were fibroadenomas. It was also relatively long ago. And then they were very surprised to see that this was grade 3 invasive ductal cancer. It was done in another institution, and then she was referred to us for additional imaging. We see additional mass in the right breast posteriorly that enhances rapidly on the first post-contrast subtraction. This is second look ultrasound of the same mass, vertically oriented, irregular. She also had positive cytology smear from post-operative seroma. So this was actually residual cancer after surgery. How do we imagine image recurrent cancers after breast conserving surgery? Now, as I said, mammography and ultrasound are difficult. It's not easy to differentiate scar and recurrence by mammography and ultrasound. Findings are inconclusive. Here you see how it often looks. Scars can have distal acoustic enhancement on ultrasound. They can be seen on mammography, but very hard to differentiate from cancer. So mammography and ultrasound after breast conserving surgery and radiotherapy demonstrate surgical scarring and fibrosis is increasing over time. Skin thickening and edema are decreasing, as well as fluid collections, but you might see them for more than 2 years. So we see edema, thickening, retraction, deformity of skin, and after radiotherapy, changes remain stable or decrease within 3 years. If we have progressive edema after 3 to 5 years, this indicates alternative changes. Now, first mammography should be done shortly after excision of ductal cancer in situ to ensure complete removal of microcalcifications, and then 6 months after breast conserving surgery for the new baseline, and then 12 months after prior mammography to resume annual screening. Ultrasound shows surgical cavity, which we see here. Initially, it may have hemorrhagic or clear fluid. Over time, internal septa due to fibrous bands develop, and then there is a reduction until a solid scar will form. This is example of 2 patients, one who has scar and no recurrence, and the other one who has recurrence after breast conserving surgery for invasive ductal cancer grade 2. Basically, you cannot differentiate them based on these ultrasound images. Both are stiff, scar is even also quite stiff. Now, the role of MRI is quite high here. There were a lot of papers published, and in minority of articles, I would say that it was concluded that MRI could influence the further policy, but MRI definitely has increased sensitivity as compared to mammography to detect recurrences. These were papers published 4 or 5 years ago, and basically, even then, it was clear that, so you do see enhancement in the scar that may persist relatively long, usually up to 9 months. It may be strong, and then it weakens or wanes, and no significant enhancement is seen after 9 to 10 months in more than 90% of patients. There was a nice paper by a past president of Radiology Society of North America, Mary Mahoney, about post-operative enhancement on breast MRI, time course and pattern of changes. So you can either have type 1, cavity wall and seroma, type 2, thin linear pattern. Type 3 is clear enhancing irregular mass, and of course, type 4 is typical MR finding of fat necrosis. And they examined more than 150 patients after breast conserving surgery, 43 after surgical excision of atypia, and 4 after benign excision, and 33% of 200 MRI scans had enhancement at surgical site, more common in patients who also had radiation. And interestingly, it was present at 40% patients beyond 18 months, but quite uncommon after 5 years. And this type 3 of mass enhancement was most commonly associated with malignancy, as we would envisage, because this is typical MRI malignant tumor pattern. So mass enhancement plus washout kinetics are most predictive of tumor, of recurrence, and this should prompt biopsy and re-excision. Look at this case. This was 46-year-old lady. She had breast conserving surgery of her left breast 15 years ago when she was very young, only 31. It was invasive ductal cancer grade 3 with positive axillary lymph nodes. These are mediolateral oblique projections on mammography. So left breast was operated. It is smaller, but I think that you agree that it's not easy on mammography to say that there is a residual cancer there. This is ultrasound and shear wave elastography, where we see this irregular hypoechoic mass, which is very stiff, 240 kilopascals. But when you do post-contrast T1 subtraction sequence, you clearly see here enhancing irregular mass. She had plateau type of kinetic curve. She was biopsied, and it was again grade 3. Invasive ductal cancer, HER2 negative, estrogen and progesterone receptor positive. So more or less ipsilateral recurrence at the site of surgery, same type of tumor after 15 years. This is a lady who was 80 years old. She had 22 years ago breast cancer surgery. This is now grade 2 invasive ductal cancer. We see this enhancing mass here. Negative estrogen and progesterone receptors, referred to MRI after mammography and ultrasound in another institution to differentiate scar versus recurrence. So we do see often, even so late, after 22 years, we see these findings. This is on-color Doppler hypervascular with irregular distribution of vessels internally, and on shear wave elastography, we see very stiff lesion, 190 kilopascals maximum Young's modulus of elasticity. Regarding MRI screening in women with prior breast cancer, there are several papers. Not to go too much into details, figures are comparable to rates of malignancy found in MR screening of high-risk patients, which we know which patients are high-risk, BRCA positive and so on, with more than 25 to 30% risk. So MR screening would be there. Justified. Excellent paper from Israel has shown comparing women who had genetic and familiar predisposition compared to the women who had previous breast cancers, that more cancers are found and also high-risk lesions in a group of women with previous breast cancer as compared to women with personal history of breast cancer that usually are referred to MRI regularly in a yearly interval. So there is a need to do MR screening in these women as well. This is an example of less a common recurrence case on MRI, where we see 73 years old patient with this huge enhancement on the left side. She had invasive ductal cancer and radiotherapy, and this was angiosarcoma. This is most malignant of all and rare breast cancers that grows rapidly with blue-red skin discoloration, and preoperative diagnosis by fine needle aspiration and core biopsy is difficult. It's often underdiagnosed and misinterpreted as benign, and it's known to develop after radiotherapy of conserved breast after 3 to 11 years, and post-radiation changes in the breast make the diagnosis of angiosarcoma very challenging. Then we have benign changes that mimic recurrence. This is the most common 55 years old patient who had breast conserving surgery of right breast for invasive ductal cancer and then radiotherapy. We see this lesion here. This is quite typical for fat necrosis. It's called the great mimicker and can be seen after percutaneous biopsy, surgery, or radiotherapy. It can result from accidental trauma and typically presents as superficial, usually periareolar, small, painless, ill-defined mass or nipple retraction may be associated. It may enlarge, it may remain unchanged, regress or resolve, and cystic degeneration may occur. This is also a typical example of large fat necrosis in a lady. Now, regarding imaging for recurrent cancer in reconstructed breast, we can use prosthetic implants for reconstructions, or, as I said, autologous myocutaneous tissue flaps. Regarding asymptomatic patients, it's considered in still valid recommendations that routine dynamic contrast enhanced MRI is not recommended for average risk group, only for higher risk groups that would qualify for MR screening. But in symptomatic women, when mammography and ultrasound are either negative or equivocal, then MRI is indicated. Regarding breast implants, we'll go fast over it. There is no evidence of increased risk of breast cancer in women with cosmetic breast implants, so there is no evidence to recommend periodic contrast MRI. But there is some added value of MRI for recurrence diagnosis in patients with implants after cancer surgery, in comparison with clinical breast examination and ultrasound and mammography by 2 studies. So in case of cancer and reconstruction for cancers, this is indicated where we see this abnormal enhancement on subtraction image adjacent to implant with segmental distribution. Or in this case, she was 45 years old. She had surgery 18 months ago. She had invasive ductal cancer plus DCIS component, grade 3 cancer, and implant was positioned in the right breast. And now we see this clear recurrence on MRI and also on ultrasound. This is an interesting case, 61 years old lady, cosmetic breast augmentation 25 years ago, referred to imaging with suspicion of implant leakage. So she was very reluctant to undergo contrast-enhanced MRI. We did ultrasound first, which was suspicious in both breasts, as you can see. She was very worried about leakage of implants, but she didn't have leakage of implants. She had bilateral invasive lobular carcinoma. And we know that invasive lobular carcinomas are much more often bilateral and multicentric, and she had ILC regardless of her implants. Regarding myocutaneous flaps, the surgical techniques are very advanced now, and aesthetic results are very, very good. So we can also use free deep inferior epigastric flaps, which is very popular now, and results are very good, as you can see, and different types of flaps. These muscular flaps on imaging are very dark because of course, fat on mammography, and also then on MRI, we have to look for enhancement. On mammography, recurrences after reconstruction resemble primary tumor. These are speculated masses. You can see microcalcifications. On ultrasound, vertical mass with irregular margins, internal vascularity. Ultrasound is, by the way, more sensitive than mammography in this setting. And then on MRI, we see mass with irregular shape and avid early enhancement. This is a patient who had triple negative breast cancer, primary reconstruction of left breast, and she has this enhancing small area here, which was very stiff on shear wave elastography, vertical, irregular. This was recurrence within the reconstructed breast of invasive ductal cancer. This is another patient. She was 49 years old. She had mastectomy with reconstruction of left breast with myocutaneous flaps 2.5 years ago. It was triple negative breast cancer, so quite aggressive type of cancer. And she had now clear recurrence in myocutaneous flap, but also in contralateral breast. So we have to think about this. Also, we have shown that stiffer lesions should be considered suspicious on second look ultrasound in post-operative breast. And shear wave elastography can be a helpful tool in this setting in identifying malignant lesions, especially if this is related to abnormally enhancing lesions on MRI that demonstrate restricted diffusion. So we always, of course, have to combine all three modalities, but definitely MRI is the best. In a second look ultrasound, we regularly utilize for many years shear wave elastography and find it very useful clinically. Regarding findings after reconstruction, I have to say most findings are benign. This is a paper from France in almost 120 women who underwent MRI after mastectomy and breast reconstruction. 37 had abnormal findings, and out of this, 32 were benign and only 5 cancer recurrences. Out of these benign findings, most commonly we can see fat necrosis that we have seen already, fibrosis, intramammary lymph nodes where ultrasound is excellent to diagnose. Then we had some papillomas were observed, fibrocystic changes and granulomas. So I hope that in this short presentation, I was able to show you the role of mammography ultrasound and especially MRI in imaging of the breast after oncoplastic surgery. This is an area that is often neglected, but we need to be aware that recurrences are quite common and that this is our daily bread, and that basically those women who underwent oncoplastic surgery will be our patients for life and should undergo regular imaging follow-up. Thank you very much for your attention.
Thank you very much, Professor Brkljačić. Yeah, it was a great pleasure for us being with you today, even if only through the video. On this, I would like to thank you for your attention. We really appreciate you being here, and we really hope also that we will see you next time. Take care, everyone, and bye-bye.